Hi, do you hear me?
Yes.
Yes.
Perfect. I apologize for the delay. Sorry, Laura. Sorry, Marcelino. Maybe we wait for a few minutes till the others are here, because I think the master students should be 8, and we have 3. Laura, I don't hear you. You are muted.
You hear me now?
Yeah, I hear you.
Would you check, please, if is here? Because she was not able to accept the lesson.
Sorry, who is she? I did not hear the name, Laura. So who should join?
We also have 2 master students, Londa and Ishita, and they seem to be waiting for you to let them join. So they said they are already in the Zoom waiting list, but they cannot join, obviously.
Strange.
And Pakrat as well. He's also waiting.
Yeah, and another one of our master students, Fahad.
Okay, maybe I can share the link again, because I used the same link we used before.
No, they are in the waiting room. You can
Yeah, but
accept them.
Yeah, but there is no one in the waiting room. There is only the 6 of us. Like, you were in the waiting room, but let me check 1 second. Hi, Kara. I don't know what is the problem, but I don't see anyone in the waiting room. I will send an invitation again. Maybe there is a problem with the invitation. Is it possible? Okay. Yes, now I can see. Yes. Perfect. Now it worked. Okay, thank you. So,
Oh, yeah. Very good. Hello, hi, Ibrahim.
hi.
I couldn't join.
Yeah, I'm sorry, I did not know what is maybe there was a problem with the link or something, and then all of them appeared all together.
Oh, okay, that's very nice. That's very nice. No, I always have issues with Zoom. I don't know why it's. So I thought it was me, but I'm glad it worked out.
I think.
Should we wait, or should we? Do you have the list of participants?
Yeah, I think we are complete.
Okay.
Please, Khader or Londa, correct me if you think there's anyone missing, but the number is correct.
I know some of. I'm just scrolling down the names. Well, I know I recognize some faces. I know some of you, and for all the others, you're very, very welcome to this lectures that I'm gonna share with Ibrahim Hanafi, who is he's a PhD student now the last year in my group. He has been working very actively in the field of movement disorders, Parkinson in particular, focusing on molecular imaging most recently, and so that's why I will leave him the stage to start with the lecture, and I will jump in to integrate if needed, but I think it will not be much needed because he has done a very, very good work in the past years, as I said, focusing on Parkinson's disease with a very intensive multimodal approach of investigating motor disorders in Parkinson patients, combining molecular brain imaging, cortical and subcortical recordings, and kinematics. There are also online some of the engineers, particularly Chiara, who is a postdoc in my group. So if you have a little bit more technical questions, please feel free to interrupt us. Let's make it very, very interactive so that you can learn the basic of the techniques we're using and apply them in your field of research. With this said, Ibrahim, please, the stage is yours, and I am here in the background helping you out through this afternoon of lecturing. Thank you.
Thank you very much, Ioannis, indeed, for your kind words. Okay. So I hope now you see my screen. Okay. So I will start with a brief introduction to the disease we are gonna work on. So I believe that two of you at least have a medical background, or you are already Farhad specialized in movement disorders. So if you want also to have a little bit of break, but I think we should do this because not all of us are on the same level. Okay, so the most common movement disorders, movement disorder can be Parkinson disease. If you can look in here, can you please tell me if you see any of the symptoms, if you see anything abnormal about the movement of this patient? Please, let's keep it more interactive because it's 4 hours. It will be also tiring if one of us keeps talking for the whole 4 hours. It'll be dead.
Yeah,
I see something.
Yeah, so please.
bradykinesia.
Mm-hmm. Okay.
What is bradykinesia?
Bradykinesia is progressive slowness of the movement and lack of and paucity of movement.
That's correct. And it has a peculiar feature. Sorry, Ibrahim, but I really want to, let's keep it very interactive. So it has a peculiar definition, bradykinesia, slowness of movements through the entire time of the movement and for the entire range of the movement. So that's something that you really have to keep in mind. And that's correct. What is the difference between bradykinesia and akinesia? What is akinesia?
Lack of movement.
That's also correct. That's correct. And what else do you see? Sorry, Ibrahim, you continue. That's
I think in the
Problem.
beginning they were trembling or shaking. Tremor?
Yeah.
I don't know what to call.
You see it now in the very beginning of the video. You can see a tremor more significantly on both legs.
And then her
What?
finger to thumb response is okay.
Yeah.
Her eye movement seems okay.
And here, what can we see about the gait?
Slowness of movement. So bradykinesia.
I don't know how it's called, microbasia. It's like shortness of the steps.
Going
I
back
think
to the
I have
tremor
it
for 1
in there.
second. Sorry, going back to the tremor for 1 second. What kind of tremor do you see?
Will it be intentional tremor?
No, we don't
What?
have intentional.
It's not intentional.
It's resting tremor in the legs, I think.
Okay.
So intentional, so we have three types of a tremor: the resting tremor when the patient is resting, not doing any movement, and we see that it's increasing also when he is distracted or he has any cognitive load. For example, we tell the patient to do 100 -7 -7 to trigger this tremor. The second type is the postural tremor. So if we ask the patient to lift the arms in the front of him, we will see such tremor, or if he poses the arms in front of his chest, and then we will see it more clearly on the video. And the third one would be intention tremor. So when the patient is trying to move his hand to capture something or to do any movement, then there will be more tremor when the patient is moving. And this third tremor, we tested with the UPDRS, the unified scale for evaluating the severity of Parkinsonian symptoms, with the finger to nose. So with the patient's eyes open, the patient this kind of tremor, then the tremor is increasing till he reaches the nose. So I don't know if you want to add anything else.
No, I want to make a provocative question. Don't you find quite bizarre that in a syndrome, which is Parkinson's disease, that which is predominantly, but if not exclusively, defined by akinetic rigid symptoms, there is an hyperkinetic sign, which is tremor. And I just leave it there. Food for thoughts. Ibrahim, back to you.
Yeah,
Next
it will appear soon. Okay, so we saw tremor. Rigidity, it's difficult to see on the video, but if we test the patient, the muscle tone of the patient, we try to move the arms, we try to move the legs, and also the neck, and we see how severe is the rigidity, meaning the tone. If I ask the patient to relax completely and I move the hand, then the hand should move very, very smoothly. But in Parkinsonian patients, there are levels of rigidity that I can even, in some patients, I cannot passively move the arm to a full extension. For example, I can't reach a full extension of the elbow, for example, and this is a symptom that we cannot see in the video. Bradykinesia is a very important symptom of Parkinson's disease, and it is the only symptom of the four major symptoms that need to be there for in order to have a diagnosis with idiopathic Parkinson. And then postural instability. It's also not super clear here, but we can see that the patient is also not feeling comfortable with the steps. He's hesitating about the steps, and we will see videos after words about how this postural instability can look like. So, and anyone can give any idea what is the pathology behind these type of symptoms?
Neurodegeneration.
So more specifically, it would be a neurodegeneration in, yeah, please.
Sorry, yeah, in substantia nigra.
In the substantia nigra. Do you know any specific neurons that are responsible for this, or the apoptosis happens in these specific type of neurons, or how can we identify these neurons?
It's substantia nigra pars compacta dopaminergic neurons that have alpha-synuclein pathology and Lewy body deposits.
Okay, then maybe also Farhad, you can present. I think you have.
Are the Lewy bodies, which you see here, are a cause or a consequence?
Consequence.
Of what?
Of alpha. They're consequence of these processes inside the neuron that led to Lewy pathology. So Lewy pathology is like the tip of the iceberg, and it's deposits of all wrong structures, not only alpha-synuclein but other proteins, and it may be some way to save some sort to, like, you know, to put all the wrong structures compactly.
Yeah, it's not entirely clear, but it's now most recent research suggests it might be more of a consequence. The formation of the Lewy body in intracells. Originally, it started as a cause, so alpha-synuclein deposits would produce Lewy bodies, and this would propagate the disease. But there has been some studies recently that we were actually able to wash out Lewy bodies from cells, and we couldn't stop the disease progression. So that most likely is a consequence of the disease, of the neurodegeneration of the cell death, that it's started, but oligomeric alpha-synuclein deposits beforehand. Yep, that's correct. Yep. Kader?
I just want to ask, is it possible to see Lewy bodies without any pathological features or without any pathological symptoms?
Who knows the answer?
I know the answer.
I think
Yeah, go
yes.
ahead.
As I remember, yes. It's everywhere, I think. In every cell.
It is. Yeah. It is. Actually, Lewy body pathology is, well, Lewy bodies, not pathology. So Lewy bodies are present in also let's say non-Parkinsonian patients. So patients that do not have a clinical diagnosis of Parkinson's disease. That's correct.
And that's why when they express it, they say more likely increased density of Lewy bodies. So not the that there is a dark area. Substantia nigra means the substance that is black, and these neurons here are the dopaminergic neurons that innervate the striatum, the different parts of the striatum. And these neurons include a neuromelanin. It's different from the melanin we have in the skin, but still this melanin is dark, and we can see that in the section here. On the left, for example, this is a Parkinsonian patient, and you can see that there is a lack of neuromelanin, and this is because of the neurodegeneration and the loss of these neurons that innervate the striatum. Parkinson's disease has different etiologies. May I ask you if you think it's a more genetic or more environmental disease, or a mix of both?
Okay, about 85% of Parkinson's disease is sporadic, so it's mixed of genetic predispositions and environmental factors, and 10 to 15% are genetically driven.
Yeah, and maybe can you, Khader, or Londa, or others name any genes that are associated with Parkinson's disease, or that there is a very clear association between the presence of these genes and the diagnosis with Parkinson's disease? Like genome-wide association studies, there was several, and they detected these genes that are responsible for making the Parkinsonian or are responsible for the Parkinsonian syndrome, and we can name the LRRK or PARC, different
Park
PARC.
2 and
Yeah.
7.
Yeah, the different genes of PARC. So all of these, so these important genes can cause a Parkinsonian syndrome, an early age diagnosed Parkinsonian syndrome, and more severe disease, but they do not need the environmental factor, or they need it to a lower extent. But there are many other genes that keep the patient in a predisposed situation where the environmental factors can build on this or do a second injury, and then the Parkinsonian symptoms appear. So it's a spectrum. It's a horizon of genes that are more strong, less strong. The more strong can lead to the symptoms immediately, and the less strong, maybe the patient has also a combination of several genes, and then with environmental factors that can lead to the diagnosis. Yeah. And is there any induced Parkinson's disease? Like any Parkinson's disease that we can induce with a substance?
I've read once something about a group of patients that took some something related to cocaine, and they were about like 7 patients. They were called the rigided patients. I'm not sure what was the exact name, but yeah, I think, and the pathology was related to the mitochondria. I think.
Yeah, but I believe also, I did not read about this, but I believe the most common would be the pesticides in farmers. There are a large group of patients who were diagnosed with this disease after they were exposed to pesticides. Yes, Ioannis.
Well, I think that Kedia is referring. So, well, first of all, is anyone suggesting there was an historical family that it's back in the, I think around the 80s, early 80s. Sorry, not a family, historical a group of patients back in the 80s that took a specific drug, which was the MPTP. And it was a derivative of, don't remember really the compound, the chemical compound, but it turned out that it was a drug targeting selectively the dopaminergic cells. And Dr. Langston was the one that described this patient. Was in San Francisco. It was around the 80s, and it was a fundamental discovery because it showed it brought a lot of interest to the field in Parkinson's research, because at that time we were thinking, scientists started thinking that it might have a causative effect. So also all Parkinsonian patients might have a toxic insult of the substantia nigra. And indeed, actually, MPTP was then used and is still used as one of the main compounds for to study to induce Parkinson in animals, in rodents especially. So the MPTP rodents model of Parkinson's disease is the one that has been studied intensively in the past decades. With one caveat, I don't know if you know it. I think many of you are working in the neuroscience fields, not clinically, right? So, do you know what is the caveat of the MPTP rodents model of Parkinson's disease, and why most recently there has been active research to develop other models, and we have one in Würzburg especially. So, what is the caveat of this toxic models of Parkinson diseases? There are others. There are, for example, another one is with rotenone. Another one is with 6-hydroxydopamine, which is targeting selectively dopaminergic cells. But the MPTP historically is the one that has been used the most. And the problem is that it's an acute lesioning of dopaminergic cells, which is not resembling what happens in Parkinson's patients. Indeed, clinical symptoms appear usually when the patient has already a certain percentage of dopaminergic cells and projections to the striatum. Who knows this percentage? I'm making this very tough questions because from the answers you gave me, Ibrahim, to the previous questions, you sounds like already kind of expert in the field. So I'm making more challenging questions, but I want you to reflect on some critical issues about Parkinson's disease that make also this pathology very terrible for the patient, but also very, very interesting from a neuroscientific point of view. So you need to have lost at least 40% of the body cells to have signs of Parkinson's disease, and at least 60% of the projections to the striatum. That tells us one very important aspect of this neurological disorder, which is
plasticity.
You need to elaborate more, because plasticity is not the answer I was looking for. Plasticity is something different. Why plasticity? Why do you name plasticity?
I think I meant that these neurons that's still alive can, for a certain period of time, mask the symptoms, so they can start new projections, I think, and compensate the lack of dopamine.
Exactly. So it's more a compensatory mechanism rather than plasticity. In the terms that the residual dopamine that arrives to the striatum is enough for striatal cells to compensate to have a proper functioning. Plasticity is something different. Is what happens at the cell level that changes the need, or changes in many ways, positive or negative, in front of the lack of dopamine. But till that point, so plasticity is what comes after. Till that point, the dopamine that is still produced by the residual neuronal cells and reaches the striatum is still sufficient for proper functioning of the striatum. That means that there is a compensatory activity preventing the symptom onset. And I cannot exclude that in parallel there are some plastic changes at the striatal cells, but maybe not at striatal level, somewhere down the road from the striatum. And maybe we will address that with it has been shown with some molecular imaging studies that we will touch base with more slides afterwards. And we're saying that I forgot what was the other thing I wanted to say. Well, anyway, forgot. It will come up later. Ibrahim, back to you.
Okay, and please, all the others, if you have any question or you think it's too fast or the concept is a little bit getting more complex, tell us so we can adjust. So please don't be
right.
shy.
Now
Can I
it
ask?
came up to, sure.
Sorry, I just lost connection for 2 minutes and I just really couldn't understand the last idea you mentioned about the plasticity.
Yeah, sure. No, the question. Okay, let me not put that question again. So just the point is for a patients to have clinical symptoms of Parkinson's disease, bradykinesia to start with, which, as Ibrahim said, is the fundamental aspect of Parkinson patients. Without bradykinesia, you cannot make a diagnosis of Parkinson's disease. The patient need to have lost already 40% of the nigra cells and at least 60% of the projections. That tells us that there is a strong compensatory activity at the striatal level to make good use of the dopamine that is still produced and arrive to the striatal cells for proper physiological functioning. It's more a compensatory activity so that cells make good use of dopamine without storing them in the cells for additional needs. They just make proper use of the dopamine that is still produced and arrived to the striatum. So it's more a compensatory activity rather than a plastic changes. So plastic changes is what comes up in the face of a insufficient compensatory activity. So we cannot really exclude that there are in parallel some plastic neural changes to make a proper use of the residual dopamine, but it's something that comes down the road. So when cells cannot compensate for the lack of dopamine arriving the striatum, then they put in action plastic any changes in that sense. So, and that's when you start seeing also the symptoms. So that's why I was asking. So the answer of I cannot pronounce your name. How do you Abazov? Is that correct?
Just
was that you? Who?
Yeah.
Who? Oh, okay. That was your answer. So he was right. The answer was right, but rather than pointing to a plastic changes at the cell level, at that stage of Parkinson's disease, it's more just a compensatory effect. So it just the dopamine that is still produced is sufficient for proper functioning of the striatal neurons. Yeah, that's what I said before. So, but going back to the animal model, so we said that the MPTP is an acute lesioning of dopaminergic cells. Usually, it's that potent drug that you do that unilaterally, and you do that to a certain percentage. You don't induce a complete loss of nigra neurons with the MPTP in these animals. Actually you do that unilaterally, usually because otherwise there is a high rate of animal death when you try to have a bilateral degeneration of the nigra with MPTP. But the problem is that you have an acute lesioning, which is not what happened in Parkinson's patients. Indeed, you have symptoms of Parkinson's disease induced by MPTP in rodents, also for a low dose of MPTP and a low percentage of cell loss, which is not resembling what happens in humans. That's why I mentioned that you need at least 40% of cell loss and 60% of projections lost to the striatum to have Parkinson's symptoms. Now we have, and also very interesting, That's the question for you. Is MPTP inducing tremor?
I think it shouldn't,
Why not?
because tremor is not strictly related to substantia nigra lesions.
And
Maybe.
that's partly correct, because you
Can I
need
add?
Sure.
Maybe because you mentioned that it's like very low percentage of the like degeneration. And that's why if it needs a very high level of degeneration in order to cause tremor, this medication cannot cause tremor consequently. Is it correct?
Well, it's more a threshold effect. So a striatal dopaminergic innervation loss is required to have Parkinson patients, but does not suffice. What is the only, and I will get back to that and add more on tremor, but maybe Ibrahim has some slides on that later on. But to complete the round with the animal models of Parkinson's disease, what is the there are two models of Parkinson rodents. One is a rodent. Two models of animal models with tremor. Anyone has an idea how we can induce tremor in animal models? What are the animal models of Parkinson tremor?
I'm not sure if it's what is meant to be the answer, but I think it's either induced, or it's in both ways are induced, but it's either by genetic methods or either by drug methods. So we will be able to cut down some genes from the generations of mice, or by giving some drugs to the mice. I'm not sure.
So,
Which drug?
Well, in this case, I'm not sure if it's safe to say MPTP.
No, MPTP is not producing any tremor in this mice.
So when
Any
we
other suggestion?
Amiodarone, maybe.
Nope. Amiodarone is not inducing tremor is not a Parkinson model. Any other suggestions?
when we say induced tremor, I mean, so we're basically making some changes in the dopaminergic neurons.
Yeah.
So
there is one toxin that is inducing tremor, which is inducing a PD-like tremor in rodents. And there is one species that are not rodents that with MPTP might have tremor, but only one species. They're not rodents.
I think chimpanzee.
No, not chimpanzee. So it's very tough. But the toxin that is inducing tremor in rodents is reserpine. It's the only one. And it's a very dirty drug that is no ethics committee will ever allow in the future to use it because it's extremely toxic and is blocking all vesicular monoamine transporters, not just for dopamine, but also for noradrenaline and serotonin. And that's probably one of the reasons why it's to some extent might have a transient tremor, because the way reserpine is working is by releasing vesicular content. So there is a boost of noradrenaline that might transiently induce tremor in these animals, and that they don't have tremor anymore. But the only true animal model that is having tremor with MPTP, I think it was eventually with 6-hydroxydopamine. Well, the mechanism of action is quite similar, is vervet monkeys. And we don't really know why. What is the tricky aspect of monkeys as a model for Parkinson? Why we don't use them that often? And we prefer using rodents?
They have really long lifespan, so it's would no.
No, because they recover. If you use 6-hydroxydopamine in monkeys, you could use vervet monkeys. Well, first of all, ethical reasons is there are very few labs that are using monkeys. In Germany, it's virtually impossible to use them. But it's very bizarre that if you treat them and you induce Parkinson in monkeys, let's say you use vervet monkeys and you even have tremor, then they recover 3 months, 4 months after they have no more Parkinson's signs, which is very tricky because contrary to humans, we do not recover. And we don't know why. So if any of you would like to win a Nobel Prize, that's a good way to go. Because if you find the mechanism why they recover, we could theoretically also apply that in humans. But I think we are on slide 3 and it's almost an hour. So I think Ibrahim has prepared 100 of slides. So we should, Ibrahim, sorry, back to you. I will shut up now for some time.
No, please. Thank you very much. Okay, so does Parkinson start at the substantia nigra? The answer is no. It starts deeper, so from the brainstem, and then it goes up, then to the midbrain, and then to the cortex. And we should note here that with time, if you look at the left side, so the DM, the dorsal motor nucleus, and these parts of the brainstem, with the time, if we are going to from the stages from 1 to 6, then the loss of neurons there will be more severe. On the other hand, 1, which is the cortical areas, has less apoptosis, less lipid bodies, even at the latest stage. So this is the mechanism how it starts. And when we say it is like this, we should see here the development. So in each one of these regions, we say that there is a process of neuronal loss. And the dopaminergic neurons remaining on the lower side of the figure from 100 till 0, we can see how the symptoms develop. So first, pre-symptomatic, so the patient doesn't feel anything, or it's very unlikely that the patient would present with these symptoms. And then starts, and the timeline here, please note the timeline, that the 0 is the clinical onset, meaning most of the patients are diagnosed at this point. If we are going back 10 years or 20 years, we can see some dopaminergic neuronal loss 20 years before this clinical onset, but it's very little, and we can detect olfactory symptoms, constipation, so and then the non-motor symptoms increase to reach mood disorders, sleep disorders, and then the patients usually present with the motor symptoms, the 5 symptoms that we already talked about, except dementia, which is not motor. So what is the aim for Parkinsonian patients? The aim is that if you look here, you can see that the patient is proceeding the clinical diagnosis, which happens usually at around 60 years old, and the prodromal symptoms appear, we said, 10 to 20 years earlier. In this period, it's difficult because it's still not likely to diagnose the patient in advance, but after the diagnosis of the patient, we can see here, or at 60 years, we can see that the healthy aging trajectory Sorry, do you see my pointer? It's important to ask. So
Yes, yes.
well, we would see the deterioration of the motor capacities in healthy aging people, but for the PD trajectory, we can see that it is much faster. And our aim is to elevate this trajectory to be as close as possible to healthy aging trajectory. Yes, please, Marcelino.
I'm sorry, I have a short question about the constipation as a prodromal symptom for Parkinsonism. So is it also due to the changes in the central nervous system, or might it also be due to the alpha-synuclein bodies in the enteric nervous system, which also seem to be quite early in the development of the disorder?
To tell you the truth, I'm not an expert in non-motor symptoms. So I did not read anything against that. It is the same pathology that is developing from the brainstem growing to the cortex. I don't know if Ioannis is still here. Maybe he can add to this, but maybe I can check and get back to you in the break.
I think
It's
it's
okay.
enteric neurons.
Sorry, Farhad, can you repeat?
Yeah, I think it's problems not with central nervous system, but with enteric neurons in the intestine.
Okay. Okay.
And how are they affected by the same pathologies? Can you draw for us the link between this dopaminergic loss and the enteric neurons?
Bragg proposed double hit hypothesis. So Parkinson's disease starts from two different spots in the periphery. It's olfactory nerve and vagal nerve, vagus. So years before brainstem pathology, Lewy bodies can be found there in intestine, basically everywhere: skin, intestine, nose mucus, and it's like spreading from periphery to the centrum. And I mean, that's what I know.
No.
So it's like,
Sorry,
like
I missed it. I just my computer crashed for a second. Sorry. What was the question again? Sorry, I just missed it. Can you repeat it, please?
Yeah, my original question was that if the constipation, because it's like an early onset prodromal syndrome, if it's due to central pathologies, or if it's due to the alpha-synuclein bodies that can early on also be discovered in Parkinson's patients in the enteric nervous system. So is it rather like a local pathology, or is it also due to the central nervous system, like a central pathology, so to speak?
And the answer, someone was providing an answer, was that someone from the students or?
Farhad.
Yeah, I said that I said about double hit hypothesis.
Yeah.
That it's from periphery to the central nervous system.
Yeah, there are two possibilities. It's either gut first or brain first. There has been this, it's quite recent hypothesis that followed what Bragg published that was about 10, 15 years ago, which is one of the slides. Well, there was a lot of red and pink. You had the spreading upward of the pathology of, well, first of all, one step back to the Bragg pathology is that the main limitation of that study by Bragg was that Bragg is very famous for the staging of Alzheimer's. And he applied the same methods to Parkinson's disease, basically defining at different stages with different patients, of course, at autopsies, the presence of cell loss and brain Lewy body depositions. The main limitation of that study is that it's not a functional evaluation. It's more a classic anatomopathological evaluation of cell loss, cell death. Well, that said that, now following that hypothesis, we start reasoning about the root of possible spreading and of the disease, and we came up with two hypotheses: is brain first or gut first. Brain first is from it's top down basically, and you would not have constipation as a prodromal symptom. We call it actually premotor symptom rather than prodromal, because prodromal they do not necessarily anticipate a Parkinson patient. So it's not that all patients with sepsis that would develop Parkinson. So they're premotor stage, so to say. And the other one is gut first. That is one from the periphery up. So it's bottom up. And with different, of course, premotor signs, like constipation is one of this. The gut first. Do you know why we came up with the gut first hypothesis? It's another thing that has a lot with serendipity in medicine and in Parkinson's disease as well. Do you know what are the clinical cases that led us thought about the gut first?
I know.
Yeah.
It's like people who had ulcer of stomach and got vagusectomy, so cut of vagal nerve, they seem to have less risk to develop Parkinson's disease.
Exactly. So these patients had a section of the vagus nerve, and it appeared that they had less. That the prevalence of Parkinson's disease in these patients was less. And so we thought about an enteric origin, but unfortunately, it's not black and white. So it does not explain for all patients the pathogenesis of the disease. There has been a very interesting study with molecular imaging trying to show that. And they use a combination of PET and SPECT images just to prove this two ways hypothesis. I don't know if you put, Ibrahim, did you put some of the slides on that maybe later on? Let's see. Otherwise, we go back to that because it's very interesting. It's one of the way that molecular imaging can help to directly assessing in patients also the pathophysiology of Parkinson. I have to correct myself about the rodents. So there is no rodent model with tremor. I mentioned razapine because we recently published with one of my colleagues, Nicola Pozzi, about a study on tremor with razapine. So we had we induced transiently tremor in this rats treated with razapine, but it was only just a transient tremor due to the release of catecholamine at the cerebellar level. So the only animal model with tremor is the vervet monkeys. No, just for the record. But we go back to tremor. And no, but just to conclude about animal models, I forgot to mention. So now we have a different model, which is more closely resembling humans. Anybody knows about it? I mean, Farkad, for sure you know. Are you working in Parkinson field?
Yeah, I'm a neurologist, so I work with patients with Parkinson's disease.
Good. So the animal model that we have in Würzburg, for the one of you that are not in the medical field, well, not doctors, but more neuroscientists or biologists, we developed, the laboratories of Chi Wang developed a very interesting model, which is a transviral infections with human alpha-synuclein. The advantage is disease progression in these animals. The disadvantages are recovery And also, funny enough, no tremor. And just leave it there. Then we'll eventually touch base again on tremor. So Ibrahim, it's did I answer your question about brain first or gut first? Good. Maybe Ibrahim has some images also on that later on, so we'll go back to that. Thank you.
Okay. So after we talked about the progression, we already also talked about the non-motor symptoms, which if you can look here on the right, you can see that on the left from 1 to 5 is the Hoehn und Yahr stages. These Hoehn und Yahr stages are is about the motor symptoms. So stage 1 starts from one side, the symptoms are very mild. Then stage 2, we have the symptoms on both sides, but the balance is not impaired. And stage 4, I'm explaining them because they will appear later in a comparison. So it's the spectrum of motor involvement in Parkinson's. The patients start from stage 1. The development between stage 1, stage 2, stage 3, and so on is not fixed. So there are patients who develop really quickly. There are patients where the prognosis is a little bit slower. Yes, Khader.
I'm not sure, but is this scale like really old?
The newer version, they just added a half a point between each one of them, but still, till now, the latest version of UPDRS from the Movement Disorder Society use this scale, so from 1 to 5. So it is a standard. So, for example, if you are publishing a paper about Parkinson's disease, it's expected that you mention that these patients are, which are the stages they are having. And if you look here on the left, you can see, for example, from 1 to 5 and the non-motor burden level from 0 to 4. And you can see that already at stage 1 from Hoehn und Yahr, we can see some of the patients already developed stage 4 of the non-motor symptoms. And if you go line by line at the end, for example, for stage 5, you can see that all the patients are already at the very extreme, at the very end of the non-motor symptoms. So the non-motor develop a little bit quicker and earlier than the motor symptoms. And now let's talk about the network that can explain to us. So we talked about the neurons, but we did not talk about the functionality of these neurons. On the left, let's start from the left.
One thing, I mean, since Kader was mentioning about the Hoehn-Yahr scale, it's old, but it's still, well, first of all, is a staging scale. So it tells you the stage of the disease, whereas the other one that we're using is a unified Parkinson's disease rating scale, which is more for severity of the symptoms. The Hoehn-Yahr scale is a very nice example of how things usually go. It was Margaret Hoehn and Melville Yahr. Melville Yahr was the chairman of neurology at Mount Sinai, and Margaret Hoehn was a student back then at Columbia. She came up with the scale, but it was the head of the department at Mount Sinai that put his name on it, and then actually wanted to add also the name of Margaret. It was a brilliant idea of Margaret to define this staging system. Yeah, it goes back in the 80s, even earlier than that, and has a very important value. In particular, when the patient is passing from stage 2 to stage 3, because with stage 3, patient recovers at back pulling with 3 steps, and that's a turning point, because you might have stage 1 and 2, you would say, is mild Parkinson's disease. Stage 3 and up is advanced, where of course stage 5 it's late stage. I mean, bedridden, cannot stand up from the chair independently. But stage 3 is kind of is really a cornerstone, because patients do not have they have this additional symptoms, which is postural instability, which is part of the motor signs of Parkinson, not an early sign, but one of the probably the one that has the most impact on the quality of life of Parkinson patients. Yeah, sorry, this was a little bit of a historical background just to make things a little bit funnier. Avery, back to you.
Yeah.
Sorry, can I ask, is it mandatory for Parkinson disease to start only from the one side, or it can start also with the both sides of the limbs?
So it's usually unilateral. Yeah, sorry.
Please.
So most of the cases start unilaterally, but with the development of the disease, the differences between the two sides get less and less. And we will see also, I hope we reach the slides of the molecular imaging, because till now it was just actually it was supposed to have to take just half an hour till we reach these slides, and it will become more interesting. Okay, so okay, so here. SNC is the substantia nigra part compacta, and it innervates with dopaminergic innervations, the striatum. The striatum is interacting with, is receiving the excitatory input from the cerebral cortex, and then it goes in one of two directions, the direct pathway or the indirect pathway. The direct pathway would be that the striatum is deactivating the GPI, and the GPI, what is the most important link here is from the GPI to the thalamus. This acts like a leash, so the GPI is holding the thalamus from interacting with the cerebral cortex. And when we are deactivating the GPIs, then it releases this leash, meaning that the thalamus can interact with the cerebral cortex more efficiently. And this is a direct pathway that can initiate the movement. So what is the braking system is the indirect pathway. So from the striatum to the left, the striatum deactivates the GPE, and the GPE deactivates the SCN. This means that when the indirect pathway is activated, the GPA is less activated and the SCN is more activated. More activated, then it excites the GPI, globus pallidus pars interna. And when it is more activated, then the inhibition of the thalamus is stronger, or the leash is held more strongly. Let's look on the right side for the Parkinsonian patients. The modulation that is coming from the substantia nigra to the striatum is poorer, and this takes the striatum more to the indirect pathway. This means that there is a higher activity in the striatum, and this deactivates the GPE more, and meaning that the SCN is more likely activated and the GPI is holding the thalamus from interacting with the cerebral cortex. This means that the patient is having less ability to move, and this is the reason why Parkinson's disease is hypokinetic, meaning the movement are harder to achieve in comparison to other symptoms, other movement disorders like essential tremor, where the movements are happening, where involuntary movements are happening. So in Parkinson, we need to activate this direct pathway. The most important drug for Parkinson, which is very old but still used in most of the Parkinsonian patients, is levodopa. What does levodopa do? It tries to normalize. It can't normalize the striatum, but and the most important reason is that it's not specific. The dopamine is going all around the brain, not specifically to the striatum in the direct or indirect pathway. And we can see here, but still the patients benefit a lot from this drug. And we can see without the drug, we can see here a very high amplitude of tremor. I put this video for, especially for those who are not working with Parkinson's disease. You can see also the hypokinetic movements, the bradykinetic movements.
Now you can understand why James Parkinson named it shaking palsy, because patients were really shaking. And you know that guy, that old man there, right to the patient, that's Stanley Fan. Stanley Fan is the one that proposed the Unified Parkinson's Disease Rating Scale. Was actually took the was actually a professor at Columbia University, so was one of the most prestigious centers. It was him together with forgot. Another guy, Marsden, right, in London. The one that proposed the. And this is a very interesting study. This is a very nice video that we collected in Africa, Sub-Saharan Africa. We run a study there in patients that for years of Parkinson's disease never had exposure to any medication, unfortunately, because they were not available, they were too expensive, and so on. So we did a couple of studies on the effect of levodopa, first administration of levodopa in patients that had long disease duration without being exposed to any medication, which is something that never happens in Europe. So you will not withhold medication to Parkinson's patients. And as you can see, the nice thing of this video is not just a remarkable improvement with levodopa, but also that despite of that you have this remarkable improvement despite long time, so an advanced neuronal loss and innervation to this trait. There is also another important message that we got from these patients is that some of this developed dyskinesias that are involuntary movements related to the assumption of levodopa, despite having not been treated for years with levodopa. That was one of the open question about dyskinesia, pathophysiology. So that is it levodopa, long for years, a long-standing treatment with levodopa that it's inducing the onset of this involuntary movements like dyskinesias, and the answer was not, because when we treated this patients, Sub-Saharan patients, with the very first dose of levodopa, some of them developed dyskinesia. So it's more disease-related and dose-dependent rather than the time the patient were exposed to levodopa. Yeah, well, that's very, very technical. I mean, more for the neurologist, but it was a fundamental study that we were able to conduct in Africa, thanks to these patients, and it's the value of this video that Ibrahim just showed you.
Still, levodopa patients on levodopa face a group of side effects, including also depression, including it might lead to suicide, anorexia, vomiting, nausea, and there are a spectrum of side effects. And this was a reason why there was a search for additional options and additional therapeutic options. We can see here still the early stage, mid stage, late stage of Parkinson's disease and the symptoms associated with each one of them. We can see that later on DBS was introduced. DBS is indicated not at the beginning, at the start, or at the diagnosis of PD, a little bit later on, although there are suggestions now or studies going on to detect where is the best time to implant the patient with deep brain stimulation. However, till now, it is happening at mid-stage after the patient has developed severe symptoms and before the patient is held to the bed and all the neurons are lost. Back to levodopa. Here we can see that the dose of levodopa, which is fluctuating. So after the patient is taking the medication, the level of levodopa is increasing and then decreasing before the next dose, so end of dose. And we can see different colors in the background. These different colors represent the green is the therapeutic window, meaning we want the patient to stay here. What does the red or the pink represent is the off state, meaning the patient is falling or the level of levodopa is falling less than the necessary for keeping the movement going on. And the patient experienced the bradykinesia and all the symptoms we already talked about. But still, if the patient is having a little bit of additional dose of levodopa, for example, or right after the administration of the levodopa, it can also reach dyskinesia. And this is an important problem for levodopa because the patient is hyperkinetic. There are a lot of dyskinesia, meaning more involuntary movements that the patient would not prefer. What is important here is that the window of the therapeutic window is narrowing over time, meaning at the end, in advanced stage or in later stages, the patient is always experiencing a little bit of off state at the end of the dose and a little bit of dyskinesia at the beginning. And this can be solved by deep brain stimulation. Then it is important to note that Parkinson's is not a stable disease. So the patient is not experiencing exactly the same level of symptoms every day or also every hour of the day. There are differences in that is according to the circadian rhythm. There are differences also seasonal effects. There was also suggestions that that might be affected by holidays and so on. And this is important about the management of Parkinson because it's not a fixed management that we can give the patient and then the patient is stable over time. Let's go back to this. It's not as simple as we can see here. It is actually a little bit more complex. We can see here that the connections are not as simple as we presented. Still, the concept is there. You can see that the SCN and the GPI are more active in the Parkinsonian state, meaning they are holding the thalamus from interacting with the cerebral cortex, but the connections are more complex, and it is like circuits. The basal ganglia, thalamus, cortex it's like a system. This loop is like a system of several loops, and these loops are non-linear. They are entering each other, so the effect of one node to the other is also continuing through other nodes and returning to this node. And the basal ganglia disorder looks like circuitopathies. What does it mean? It means that each one of these nodes is behaving, is having its oscillatory activity, and it's activating or deactivating or influencing the effect, the other nodes in this system with this activity. And these circuits are interacting with each other through, it's like a radio wave, and they are activating, and the information is flowing through this loop in a specific frequency, in a specific oscillatory activity. And when we are disturbing one node, we are disturbing the whole circuit and possibly also other circuits. If we take this is an update of the basic understanding of the function of these nodes. However, we also need to update the understanding of the of this figure here, the progress of the disease from the brainstem going up to the cortex. And what can be an update for this? It can actually, there's a mistake here. Yeah, I apologize. Yeah, do you see my screen now?
No.
Uh-huh. Yeah. Let's think about this circuit as also an electrical circuit. There are the cables, which are the anatomical connections between the different nodes. There are also some kind of activity, the light here, and it represents that if I'm putting a probe or a deep brain stimulation electrode or whatever in a node and I'm collecting the activity, what I see is the activity just at this node. And it is like the light bulb here. The light, I see the effect or the activity I see at this node. However, I need a little bit of more resolution. Imagine that we can also see the electrons that are passing through these batteries and to the light bulb. And this is what we want from the molecular imaging. We can think about the cables, as we said, as the anatomy. The physiology is the function of these connections, as we saw through the circuits, but there are still the metabolism. So how is it working? How is the physiology working? Where are the molecules moving from one side to another? What is the problem with these molecules? And this is not possible with functional MRI, for example. It is more likely to happen with the molecular imaging. So functional, let's say the functional would tell us about blood flow, oxygenation, which are indirect reflections of the activity in these regions. It has very high temporal resolution and also the dynamic changes. So I can put the patient in an fMRI scan, ask him to do different tasks. And during this performance, I can detect the activity, see what is happening. But what can molecular imaging offer us? It still can offer us the spatial resolution, because I'm still scanning the whole brain. It's not that I'm collecting one probe from one or the activity of one specific place, but it is more specific. I can see specific molecules, radio tracers, specific targets, receptors, whatever. And this is important. Can you please tell me if you want to employ molecular imaging for movement disorders, what would be your aims? So what are the benefits that are you looking forward to get from these types of molecular imaging, meaning SPECT, PET scans, positron emission tomography, and so on? Or what do you think that we are missing in the anatomy or the physiology or the anatomical imaging and the functional imaging?
Well, it's also better for differential diagnosis. So because sometimes if you have like secondary Parkinson diseases, which can also be triggered due to different various effects, you will not, like a normal MRI scanning would not be sufficient. So you would have to see if there's really some deficit of the dopamine transporters going on, where you stat scan, for example, for Parkinsonian syndromes.
Okay, so it can help, as you said, Marcelina, thank you for the diagnosis. Also, possibly the prognosis to detect if the patient will do better, will do worse. So what can also be a benefit of molecular imaging? A more direct benefit. If, for example, I'm given... Yeah,
I
please.
don't think, I don't know if it's the correct answer, but maybe it's good because it will detect the activation, the direct activation of the regions.
So when, for example, I am giving a medication or applying a therapeutic plan or implanting the brain stimulation electrodes, I want to see the effect of this on the metabolism, on the molecules. How is it changing the brain? Because it might take a long time till we reach anatomical changes. And functional imaging, as we said, is an indirect impression. It gives us an indirect impression of the activity. And this is important because I can optimize my management based on such scans. So the most important things here are the PET and SPECT scans. The PET scan is positron emission tomography, and we give the patient, in each of these scans, we give the patient an injection in the veins of the patient, and then this radio tracer, this molecule is traveling around the body through the blood, and it is getting uptaken, or it is still going around in these regions. And then I do the scan and I detect the radio tracer. Where is it placed after this injection, after a specific time of this injection? So in the PET, we give a positron emitting radio tracer, and this positron emitting radio tracer gives a positron. This positron, if you can look on the left side, after it is there in the place, this positron collides with an electron and gives a gamma activity, gamma rays, in two different directions, or in two opposing directions. And I detect this with the circle of detectors of the PET scan. This gives me higher spatial resolution in the PET. On the other hand, for the SPECT, I'm giving a molecule that is gamma emitting itself. So it's giving gamma. And for the SPECT, I have the detectors in a row on one side, and this gives me less spatial resolution due to the way that I'm capturing the activity, the gamma activity that is emitted from the body. Another benefit from the PET scan is that I can do more quantification. For example, if I'm trying to detect the level of metabolism of glucose or oxygen, then it would be more preferable to take a PET scan. But the SPECT scan is less likely to give us enough quantification. And but the best thing about the SPECT scan is that I can use different radio tracers in the same scan. So I can give several things, giving also the gamma and detect them in the same time. But for the radio tracers of the PET scans, I need to give only one molecule. And for example, the most common would be the FDG. So the FDG is a glucose that has a fluoride that is radioactive, and I detect this activity after the molecule is taken into the cells. Then let's start from here. let's take the dopamine in the bottom and see what can the molecular imaging offer us about this. If we study the dopaminergic pathways, we said they start from the substantia nigra. The most important pathway is the nigrostriatal, which is going to the striatum, and this is the pathway that is affected in Parkinsonian patients. There are other pathways that are going to the cortex or downstream to the median eminence. However, these are less affected in Parkinsonian patients, and they will be studied less in the literature. We have above here the substantia nigra neurons, the end of these substantia nigra axons that are targeted towards the receiving neurons in the striatum. And we can see here the red dots are the dopamine molecules, and there are different receptors of the dopamine in the striatum neurons and also in the substantia nigra neurons. First, let's take the first receptor, which is D2-like at the receptor neurons. And here we should think about all the possibilities. There are different BET and SPECT ligands that I can study for presynaptic and postsynaptic. And the most important for postsynaptic can be the raclopride. And for this molecule, I am detecting the capacity of the D2-like receptors to bind to my molecule. And let's think that this receptor, we said, or let me say, we said first that dopamine in the brain is not completely depleted when I'm diagnosing the patient. There are still some neurons that are compensating, so there are still some dopamine, endogenous dopamine in the brain. And this dopamine is going from the substantia nigra to the striatum. And we see that the symptoms are fluctuating in Parkinsonian patients. And this fluctuation means that this dopamine can also be fluctuating in the brain. So if I'm trying to use a molecule or a molecular imaging study to optimize my treatment or to help me in the diagnosis, I need it to be stable. So if I don't want the patient to have a good scan, a healthy scan, if he's in a good mood, for example, and vice versa, I need something more stable. In this study, they used this raclopride PET scans for a group of patients. It was a randomized control trial. They took a group of patients and they gave them only placebo. The 4 group of patients were administered placebo, but what was the difference is that they told them that the possibility of you having levodopa in this placebo is 25. So the patient was blind. The patient was not knowing what is he taking, but it was always a placebo. However, he was told, every patient was told a percentage ranging from 25 to 100%, meaning the patients with the 50% were told, we are giving you a drug and it is 50% likely that it is a levodopa. And then they tried to detect if there is any clinical improvement in these patients, because we said about this fluctuation, this effect of the psychology of the patient. So we can see that there is an improvement even for the patients who were told 25%, but the significant improvement was, or the highest improvement was in group C, which were told that there is 75% probability that you are getting the medication. Now we want to see if this is affected by the metabolic changes of the dopamine in the brain. So the uptake of this dopamine in the receptor neurons in the striatum. These are the scans at the baseline, and these are the scans with levodopa. You can see that it is a little bit decreased, the activity, because when the patient is having more levodopa, then the receptor that we talked about here is occupied, and then the raclopride will not have a place to attach to. So the capacity of binding to this receptor is less likely when there is enough dopamine going through. And we can see here that it is less activated. However, what is important here is that in the placebo, we see also the same effect. And this is something interesting because first we saw that there is a clinical improvement just with a higher probability of expectation of the patient. So the patient, I remind you that the patients in all the arms were receiving placebo, but their expectation, their higher expectation of getting the drug led them to have a similar scan to having actually getting levodopa. And this is something that will not help us a lot optimizing the treatment. Is that correct? Because if I'm trying to administer a drug and I know that the effect of the endogenous dopamine can give me a fluctuation that is similar to the effect of the drug, then it is less likely that it will help me. Do you agree?
Ibrahim?
Yeah.
Okay. One thing which is quite important. I don't. You said it, but I wanted to stress it out. This is a very interesting study by the group of Stoessel in Vancouver, and it's not a study only on the placebo effect, which we know is very important in Parkinson's disease, but on expectation. Because all these patients, the patients that took part of the study, were on chronic levodopa treatment with very high benefit. So basically, to all the patients were provided with 4 jars. They were told, okay, if first jar there are 100 pills, and 25 of them are levodopa. So they have 25% likelihood to pick up a levodopa pill. In the second jar, 50%, then in the third one, 75%, then in the fourth one, 100%. So in the fourth one, they were sure of taking the medication. In the others, they were sure about taking medication, but it was placebo. So they were convinced of taking levodopa, but they were actually taking placebo. But it was on the expectation of getting a medication that was beneficial. They were improving the symptoms. What they found is that when the patient were confronted with the highest likelihood of getting the medication, they were actually not, was all placebo, they had an endogenous release of dopamine that was equal of the medication effect. So they were actually improving clinically to the same amount of the true levodopa pill. And they were able to show it with this raclopride pad, as Ibrahim was suggesting you, using a very elegant approach, which is called a displacement study. So basically, there is a competition between the ligand, raclopride, which binds D2 receptors, and levodopa itself. Indeed, raclopride pad is one of the exams that you can do by withdrawing pausing medication for at least 12 hours. So they noticed, and you see that in confronting panel B, the picture B and C. So you see the baseline, which is showing you the reduction of D2 receptors. You see it's a little bit less red on the left striatum. Now go down to the baseline, left. Okay, that one. So you see there is less, it should be all red in normals. In Parkinson, there is, it's a color coded, so less color, it's less dopamine receptors. Then you see when you're giving levodopa, you're doing the PET, levodopa competes with raclopride, and you have a further reduction of the binding potential of the raclopride to D2 receptors. They achieve the same reduction of the binding potential by providing the patient a pill that was placebo, but from the jar, where there was the highest likelihood, 75%, of getting levodopa. So what they showed is that just the expectation from the patients to get a drug that is known or believed to do good, to improve symptoms, is releasing endogenous dopamine to an equal effect as levodopa, which is the most potent drug that we have for Parkinson patients, to the same effect of which was 200 milligram levodopa. So this is extremely important, especially for randomized studies when you are testing new drugs. So the way you are eventually proposing the drug to the patient, that's why it's so important to randomize double-blinded. So also the neurologists have to be blinded, because if I'm confronting the patients and letting the patient believe, understand that it's going to be a drug very important for the improvement of the symptoms. So with a high likelihood of improving the symptoms, the patients might have an actual benefit that is related to the belief of getting better, rather than the impact, the effect, the chemical effect of the drug itself. Yeah, sorry, I just wanted to underline it, because it's very few studies that are so elegant in addressing the research questions so precisely as. Londa, do you have a question?
Yes, I was wondering why is this why is such a big result in the last group?
Yeah, that's the point.
If they know that
exactly, it's not the truth. So in the group D, they were sure of taking the medication. So there was no expectation. It was a fact. They knew what were they taking. So they were told this jar is just levodopa. So there was no expectation, no risk. So let's say no risk, no gain. So there was no risk at all. No, the true question is, why 75% and not 50? Because with 50%, you have the highest risk. So 25, the risk is too low. You're just betting to lose. 50 is the highest ratio you could get between gain and so risk and gain, rather than 75. And it's very difficult to justify it. They try in the study that saying that, and that's known, Parkinson patients do not have a correct risk to gain perception. So given to the fact of a lack of dopamine, which is intrinsic in Parkinson's, which is pathognomonic in Parkinson's disease, they cannot properly assess the risk. So the 50-50 is, so the 75-25, which is the one that was spotted to induce the highest endogenous dopamine release, is actually perceived by the patient as 50-50. But it's difficult to, that's just an hypothesis. They could not really come up with a good explanation. But if you think that it's if it's really high risk, high gain, then the 50% should have produced the most dopaminergic, the most endogenous dopamine release, rather than the 75. But the 100%, going back to your question, that's certainty. There is no risk in that. So there was no endogenous release of dopamine. And so it took me approximately 20 lectures to properly explain this slide and understood this study. So if you're not confident or pretty sure about that, I will really suggest you to take down the name of the study and read it, because it's very elegant. I hope I could make myself clear, and Ibrahim as well, because it's very difficult to explain it, but we tried our best.
Actually, no, you explained it very well. I was just inspired, kinda, with the fact that the expectation might modulate the clinical onset. So maybe other expectations also could increase the endogenous dopamine level, like any other expectation. I don't know.
Well, it's like
it's just a fact.
Yeah, it's like the expectation when you're going to the dentist, you don't have any more any pain, tooth pain. It's the same. It's paradoxically, it's kind of the same thing. Actually, you are so scared, you'd rather not go there that you don't have any pain. Or like when the patients, Parkinson patients, come to the office, to the clinic, they usually do extremely better than at home. Is the expectation to improve. It's motivational, in other words.
And as I told Londa in a previous slide, it's not expectation is a very important thing, but also the situation. We say that even the spring, the summer, can affect how the patient is doing. The festivals are affecting the circadian rhythm. They are all affecting. So, okay, to go back, then let's check other ligands. The dopamine is coming from the substantia nigra neurons getting released, and then after the release of dopamine, there is a receptor, the DAT reuptake receptor, and this is taking the rest of the dopamine that is left in the interneuron space to the vessels again to the substantia nigra neurons. And there are actually the presynaptic ligands that we can also with them check the density of this that reuptake. The most important of them, which is the FBCIT, which is the DAT scan. The DAT scan is a molecule that we inject to the body as well and do the scan. It reflects the molecule is of two parts, the iodine part, which is radioactive isotope, and the FBCIT part, which is the ligand that is getting connected to, attached to this receptor, to the DAT receptor. If I have more of this higher density of the DAT, then I expect a high density of the DATs, especially in the ends of the neurons that are going to the striatum. So in the putamen, in the caudate nucleus, we have a high density of them because it is appearing at the end of the axons. And there is less density in the rest of the brain. However, in Parkinsonian patients, we say that these neurons that are innervating the striatum are getting lost. This means that with the apoptosis, I would have less and less that density in this region. And you can see this. For a healthy control subject on the left, there is high density of this receptor in the striatum region, and this is getting lost more and more till we have the BD Horn und Jahr stage. These are the stages that we talked about before, and as stage 4 is a patient have a high severity stage. However, we also need to check with the years, meaning in every patient, it can also be a possibility that the higher stage have higher loss of these neurons, but I want to take some patients and check with the time if they are getting more loss of these neurons, and if this loss of neurons is representing itself as loss of that activity. And we can see here that these patients, after 1 year, that we do not see a lot of effect. Then 2 years and 7 years later, we can see a loss of the intensity or density of the DAT, especially on the left hemisphere. And this is important because we said before that the intensity or the severity of the symptoms are also not symmetric between the two body parts, and this is reflecting also on the hemispheres of the brain. Now we should think about correlating this with the severity, because the severity gives me more resolution. It's not just for stages, but also the rigidity. What I mean by severity is that we have the UPDRS, the scale that Professor Isaias talked about. It's a scale of 30 items, and each of these items detects, for example, the rigidity in the different arms, or the bradykinesia, the tremor, and so on. And we have, of these 30 items, sub-scores, meaning the score for gait symptoms, the score for rigidity symptoms, bradykinesia, and so on. And we can see here that the uptick in the contralateral putamen, meaning I can, for the bradykinesia and rigidity symptoms, have a severity score for the left and right hemibody separated. And I take the severity of the right hemibody and correlate it with the activity of the DAT on the left hemisphere, density of that on the left hemisphere. And we can see here that the higher the rigidity, the more severe the symptoms, the less the DAT density is available. And this is happening for rigidity and also happening for hypokinesia. However, we say that Parkinson is a mix of several symptoms. We need to check if this is happening for the other symptoms. And we can see here that tremor do not correlate significantly with the that density. This means that possibly this dopaminergic innervation is not reflecting, or is not responsible possibly for the tremor severity. And we will check that later on. But it's important here to say that this helps me to detect the more and less severe hemisphere in a more standardized manner, because there are also interventions like dopaminergic medications. They go to the whole system. So there is no selectivity to the right or left hemisphere. However, some interventions like deep brain stimulation, I can also target one hemisphere. And if I'm doing this, I need to know which one is the most severe hemisphere. It can be that Parkinson's, since it starts unilaterally, that if I'm implanting and healing, so to say, the most severe hemisphere, the patient gets more improvement. But it is, so the symptoms are clear, but when I have a more standardized manner, it would be better. And the DAT scan can help me with this. Now, is it always needed to do molecular imaging to detect the severity? Please, if there is any question about the last slide or the slides before, tell me, interrupt me right away. But for this slide, I'm asking, is it always necessary to use molecular imaging for all the ligands? It is actually sometimes we can sidestep the molecular imaging and get also a reflection of the innervation or of the molecules. And one important example of this is the neuromelanin, the ligand that we said about. It is sitting in the neurons that are secreting, that are innervating with dopaminergic innervation, the striatum. And when I have a loss of these neurons, then I have a loss of neuromelanin that is happening in the substantia nigra. What is important about this neuromelanin, that it shortens the T1 relaxation time. So these images are from normal T1 MRI images, not normal T1 MRI images, but with a specific sequence to detect the neuromelanin that is happening in the substantia nigra. And we can see here on the left side that the substantia nigra is thicker and larger in the volume than on the right side, which is the Parkinsonian patients, an example of Parkinsonian patients. And as we did for the DAT scan, for the molecular imaging study, I need to check if this volume loss correlates with the symptoms or correlates with the DAT scan. And in this study, it was important that they showed that the higher the volume of substantia nigra, the higher the DAT binding density in the striatum, meaning it is connected. When I have loss of these neurons, if I go to the left, less volume of these neurons, then I have less DAT in the striatum, meaning these two things are correlated. However, there are a lot of limitations of this. For example, the lack of specificity, because there are also among patient heterogeneity. I do not have a measure of this. I do not have the specificity I have when I am collecting the density of the DAT in the striatum. It is at the end hyper intensity or lower intensity. Yeah, and there are technical challenges because I told you this sequence is very special. If we go on, there are several other compounds that can help us with the molecular imaging. I can detect the different neurotransmitters in the brain, the adenosine, also the opiate system, the GABAergic innervation, and all these things would have their ligands, and I can study them. This is important, especially also for the SPECT images, because I can use also a combination of similar or several of these compounds and detect in the same patient, in the same scan, different innervation systems and transmitters. Yes, Ioannis,
Yeah, no, I just wanted to add something a little bit more technical. For the one working with animal, the one working in with animal projects. So as Ibrahim was saying, there are ligands that are designed for SPECT and or PET. For animals, usually, well, now also for humans, actually, we are more and more using PET ligands because the quality of the images is definitely superior. There are two groups of PET ligands, and you can see an example here. Just take the opportunity of this list. They could be you can either activate a carbon ion, carbon atom, or a fluoride. So they could be either 18F or 11C. So 18 is the position in the molecule. And the main difference is the decay time. With C, it's fast decay, minutes. With F, it's hours. So you can combine multiple ligands, but you have to be very careful about the decay time. So you cannot inject 2 F18 ligands, because then the radioactivity would be sum up, and you cannot distinguish what is binding what and what is actually activated. Then, so main difference is with how you, and the other difference related to F or C binding C activated ligands is that for C, you need a cyclotron. So it's a little bit more difficult to have them and use them, because they decay very fast. So between the injection, between the activation, radioactive activation of the compound and the injection, you have to be very, very fast. Yeah, so that was main criteria. So when you are eventually reading studies or thinking about a study, just keep that in mind. In Würzburg, we have a nuclear medicine facility with a high research output in nuclear medicine, mostly oriented to cancer research, but also neurodegenerative disorders. And in general, actually, for animals, you tend to use F activated ligands, because they're easier to produce, and you don't need a cyclotron, and you can the transport, for example, from the lab to the injection, it's easier, and so on. Contrary, in humans, in some cases, it's better to use C activated compounds for ethical reasons, because they decay fast, and so you don't really have all the boundaries also to have patients radioactive for long period of time. For humans, it's a little bit difficult also, because in Germany and in Europe, in most of the countries in Europe, but not, for example, in Denmark, so in not all of them, these ligands are legally they are identified as drugs. So to have a study, to run a study in humans, you have two possibilities. Either you go for compassionate use, Heilversuch, meaning that these compounds have a rather important, innovative therapeutic effect, like new therapies for cancer, and then basically you are waived. You don't really need an ethical vote for that, because they're life savings. In neurology, in movement disorders, especially in Parkinson, we cannot make such claim. So it's very difficult to use these new compounds, because we have to go through most of the studies that are required for drugs, like toxicology studies and so on. That makes things quite difficult. Indeed, some of my colleagues from Germany or also UK moved to Denmark, because in Denmark, such a rule does not apply. Indeed, the study that I was mentioning before, with trying to tackle the two hypotheses of brain first or gut first, combine exposed to patients to 4 PETs studies, 3 PET, 1 SPECT. They used, I think was, not remember the name of the compound, but they use acetylcholine PET to tackle cholinergic activity in the gut. Then they used MIBG for cardiac, that's a SPECT, tackling noradrenergic innervation of the heart. Then they used methylreboxetine for brain noradrenergic activity and an equivalent PET of the DAT scan of eoflupine. Also for the eoflupine, the DAT scan, the one that Ibrahim discussed with you earlier, now we have a PET compound. And the main limitation of bringing this PET compound to the clinic is the specificity. So that's a true limitation when you're using this ligand in the clinic. There is several studies by a good friend of us, Varrone at Karolinska Institute, who is just trying to establish the use of this new ligand for dopamine reuptake transporter. So that imaging, it's a PET ligand. The main problem is the specificity for the DAT, for the dopamine reuptake transporter transporter, in this strategy. But results are quite promising. So I think that in the next years, if a couple of confirmatory studies come up, we could substitute the DAT scan, which is SPECT by the ligand, with this new compound for PET, which is fluorinide 18. So has all the advantages of not needing a cyclotron for activating the compound. Yeah, thanks.
Thank you. Okay, and now what is the next step? There are some heterogeneity, or actually an important amount of heterogeneity in the molecular imaging. If you look here, we have 3 DAT scans. They do not look like super different from each other. However, if we take the first one, it is a male. This patient has a very important postural tremor. You can see any tremor now when the patient is resting. When the patient moves his hands to the front, we can see a little bit of tremor on the left side. For the second scan, this patient did not develop BD signs worsening after 5 years, but he has important tremor, both resting and action tremors. And you can see when he is resting on the hands in the lap, but there is no bradykinesia, there is nothing else other than the tremor. The third patient actually doesn't have postural tremor, but has rest tremor that increases when the patient is stressed with cognitive load. So we have a patient just with tremor, we have a patient just with postural tremor, we have a patient just with resting tremor, and the 3 of them have comparable DAT scans. This might let us think, and this evidence and also other evidences let us think that maybe Parkinson, since it is a syndrome of several symptoms, maybe we can target each one of these symptoms alone, meaning maybe there would be an imaging pattern or an activity pattern in the brain that is responsible for a specific symptom, and that doesn't translate to the other symptoms. And we said for the DAT density that it is very good for bradykinesia and rigidity, but not for tremor. And this is an interesting thing. Why are we interested in tremor? Because there is this follow-up study. They took a group of patients. First, I want to tell you that there is a classification of BD patients. There are tremor dominant, there are kinetic rigid dominant BD patients, and there are also postural instability and gait disturbances dominant patients. So we have also a mix of 2 or more of these symptoms. But is there anything special about the tremor-dominant PD patients? If we take a group of these patients and a group of akinetic rigid patients, and we follow them up, do they behave similarly? And here they saw that the akinetic rigid patients were associated with greater reduction in the dot density reduction, with also more severe clinical symptoms. So the development of the symptoms was stronger, and also the loss of dopaminergic inhibition was stronger than tremor patients. Then possibly we should study this small group of patients, the tremor patients, and see why are they behaving better? Why do they have this better prognosis? To check if we can also apply the same thing to the other patients, imitate the same pattern in the other patients. In this study, they took 3 groups of participants. The first one in the lower row were control participants. The one above them were idiopathic Parkinson's disease patients, and the one above them were monosymptomatic isolated. So these patients, they have just tremor. They have not developed any signs of Parkinson's disease. And they checked 3 different ligands with a BET study. So lacropide and F-DOPA and FDG, and they could not see any significant differences between any of these 3 groups of participants in the molecular imaging. The situation did not hinder the field because in this study, Professor Isaias and his colleagues, they tried to look into something more complex. It is not as easy as getting the scans and comparing the scans and detecting the differences between them. It can also be that there is a pattern that we cannot see and detect very easily with simple comparisons. So what they did is that they got a group of tremor dominant patients, and they studied them with several FDG PET scans. We will talk about the several scans afterwards. But first, a scan of simulation, nothing is given to the patients, and we want to see if there is a pattern that is explaining the tremor intensity. And this pattern doesn't have to be in a specific region, meaning we can feed in the scans and apply a method that is called a principal component analysis. This principal component analysis can take all the patterns that are happening together and try to justify the intensity or the differences among the patients in the tremor group based on the patterns of metabolic activity in these scans. Meaning, they found this pattern that you can see here. This pattern is an activation in the cerebellum and also a little bit in the caudate putamen region, and also an activation in the primary motor cortex. This is happening together, and the expression of this pattern is correlating with the amplitude. If you can look here on the right in the C panel, you can see that the expression of this pattern is correlated with the tremor intensity, the amplitude of tremor when it is measured with inertial measurement units. So what can we conclude? That this pattern, when it is more expressed in a patient, he will have more tremor. When it is less expressed, he will have less tremor. Then, if we activate the stimulation of these patients had VIM, stimulation, so stimulation in the ventral intermediate thalamic nucleus. And when we activate the stimulation, we can see that for all the patients, there is a drop in the expression of this pattern, meaning the molecular or the brain activity is less similar to what we see here on the left. And when we turn off the stimulation, it is more similar to this. And this is a proof that it is possible that we have a covariate, meaning a pattern of activity that is responsible for a specific symptom. Now we need to check if it is specific for this symptom or not. And here on the left, they called this pattern the Parkinson disease tremor pattern, I think. And you can see it in red. And there is another pattern that was already described, which is for the rigidity. And we can see that they overlap for some regions, especially in the cerebellum and the pons. However, for the other regions and most importantly, the cortex, they do not overlap. And this is important because we can say that now tremor and rigidity, they have two different networks, and we can treat them as two separate things. Then they took this to validate it in another group of patients. And in this group of patients, they took the UPDRS tremor subscale and the expression of this pattern, and they also correlate. Then we need to check if what we saw for the effect of stimulation is also important and specific for this pattern. They got two groups of patients, and they tested for them the expression of BDTB, the tremor pattern, and BDRB, the rigidity pattern, and also a group of normal controls. The first group was implanted in the VIM, in the thalamus, and the second group in the SCN, subthalamic nucleus. And we can see for BDTB, there is a higher expression for the VIM DBS patients and also for the SCN DBS patients. And when we do a retest analysis, the differences are very little, meaning that these results about the expression of this pattern are robust, and they do not change from one scan to another. I think the difference between scans was 8 weeks. But when we see the effect of STN DBS and VIM DBS, we see that VIM DBS is much more, has much more reduction of the expression of BDTB. And this is important because this says that the thalamus deep brain stimulation, the VIM deep brain stimulation, is more specific to target the tremor pattern. Let's look at the BD rigidity pattern. We have also high expression in the VIM and SCN DBS groups. And here we do not have any difference between the VIM and SCN DBS groups in the reduction of this expression, meaning the VIM was specific to reduce the expression of BDTB, and it was not specific to reduce the pattern of rigidity. And this explains what we know before, that the brain stimulation of the thalamus is more effective for tremor than in the subthalamic nucleus. Now, why is this revolutionary? Because it tried to separate two symptoms and target also express that the targeting of these two different symptoms is specific for each one of them. Okay. And the step after this is to take another symptoms. And we select gait. Gait is very important because, or let me not talk about gate now. Maybe we can take a little break of 5 to 10 minutes and then continue with gate, because most of the studies that we do are focused on gate, and maybe it is already 2 hours and 20 minutes of talking. So we can have maybe a 10 minutes break till 4:30 and then continue with gate. Is everything okay by you? Okay,
Yeah.
please tell me if it is too much, then we can also cut it short, or we can do something more easier. I can also remove some slides, but if you are enjoying, if it is okay for you, then we can move on with the gates. Okay, then see you in 10 minutes. Hi, London. Okay, do you hear me?
Yes.
Yeah.
I think
Perfect. Yes. Sorry, 1 second to share my screen. So, do you have any questions to me, to Professor Isaias, for the first part? Okay. Then, the last thing we reached was that we could isolate the pattern for tremor. And now we should look to other. Do you see my screen now? Perfect.
Yes.
Okay, so now we are interested in gait. But why gait? Because gait is very special because it leads to loss of independence. It leads to mortality. How does it lead to mortality? Patients with Parkinson's disease have postural instability and freezing of gait. And the freezing of gait is when the patient feels that his legs are glued to the ground and he cannot take any further steps. And this induces falls or causes falls, which happens in 70% of Parkinsonian patients. Falls lead to fractures. Fractures mean muscle weakness and more postural instability, or fear of falling, social isolation, the patient is not going out, loss of independence, institutionalization, and poor quality of life. Gait is a symptom that is very complex because it affects nearly all the aspects of all the variables that we can calculate for gait, the kinematic factors. It affects space, variability, the rhythm of gait, the asymmetry of gait between the two legs, postural control, the step width, step with standard deviation, also the variability. So it affects everything about gait. And in addition to this, there is episodic symptoms like freezing of gait that happens, that gets triggered, and then the patient has these freezing, and we say that it can lead to falls. What is also important about gait that we cannot treat it efficiently. Here you can see that dopaminergic medications can affect the several of these independent items that are representing gait impairment. However, the improvement is only happening for these or significant improvement above 0.5 is happening only for few of these items, and levodopa can deteriorate gait in some parameters. Is that only for levodopa? No, actually, even with deep brain stimulation, you can see here on the left, this is the UPDRS item for gait, and the patient are implanted when they are between 2 and 3, and then there is a significant reduction, meaning an improvement of gait. However, this improvement is lost with time, and we can see a deterioration of these symptoms. The score grows one more time. With the two targets. The two most common targets are the subthalamic nucleus and the globus pallidus internus. So both of them are nearly equally effective for gait, or not super effective for gait. We can see here that the difference between the two targets is not crossing the line of no effect to GBI or to STM, meaning they are equal. Deep brain stimulation can also induce freezing of gait, and this is important because we will see a study on this. So patients who do not have freezing of gait, they got implanted after the implantation with the lesion or with this stimulation. We are inducing freezing of gait. When we are turning off the stimulation, this freezing gets reduced. This is important. Now we need to employ molecular imaging to study the brain with regard to this specific symptom, which is gait. And why do we study brain? The brain, for example, why don't we study the brainstem, the spinal cord, or whatever? Because actually for the Parkinsonian patients, these locomotor structures, and also specifically for gait modulation, these locomotor structures, the subcortical or the spinal regions, are more dependent on the supraspinal input. And by the supraspinal input, we can see here on the right a very complex network of regions that are contributing to the effective gait. Gait modulation is also another issue because it requires cortical integration, and the patient needs to plan for the steps that he is taking and so on, plan the locomotion pattern. So it is really important. Then we have the deep brain stimulation implanted in the brain. So we can also detect with the molecular imaging the effect of this implantation in the subthalamic nucleus or the globus pallidus internus with its effect on gait. Now, we want to study the metabolic activity of the brain. However, first I need to understand how significant it is. We study the brain with different things. We can study with fMRI, with functional connectivity, functional brain imaging. We can study it with FDG PET or H2O PET or FNIRS. So fMRI and FNIRS, these two things reflect the blood flow, the perforation of the different brain regions. This is important, but as we said before, it is an indirect measurement of the activity. If I want something more direct, I would choose FDG PET. What is FDG PET? Will come in the next slide. But FDG PET is a glucose metabolism in the brain cells, and this is more specific. Then if I want to study gait, I have two possibilities: either to study patients who they have gait problems, but when they are resting, or to study them while they are walking. And if I want to study actual gait, I can use the SPECT and PET imaging and FNIRS, but I can't use fMRI because the patient can do effective stepping. He can carry the device and walk with it. So it's important that we use one of these imaging techniques. FDG PET offers us one additional thing, which is the sensitivity to neural activity, and it is less affected by movement artifact, which happens for EEG, for other techniques like FNIRS. Then, what is FDG? Is fluorodeoxyglucose. This molecule is a glucose And if we understand the brain cells, when they are more active, they need more glucose. However, this glucose is something like fibers. The cells can take, but they cannot consume. And this is the trick that we use. We let the brain starve, then we invite the patient to the hospital. We let him get this glucose by the veins, by intravenous injection. During this, he can be resting and he can be doing the task. So I inject the patient and let him do the task, the actual gait or gait modulation or whatever, what I want to study. So these glucose molecules get into brain areas that are more active. Then I put the brain of the patient in the scan. This study also used FDG PET, but they got a very large sample of patients. And here we are taking one step back. This is a BD-related pattern. So this is a general BD pattern. We can see the expression of it, a little bit of hypometabolism in the cortex, a little bit of hypermetabolism in the cerebellum and the subcortical regions. And as Professor Isaias did in his study, they checked the test retest. Test retest is something really important because if I'm doing a scan, I want the scan to be similar after 1 month or 2 months. Otherwise, it's not a biomarker. It's not a surrogate thing that I can build on. Then STN lesion, STN DBS, meaning STN lesion when I'm implanting in the SCN or using other methods other than deep brain stimulation. But the lesions to the STN, which are effective for the Parkinsonian symptoms, reduce the expression of this pattern. Okay, now, practically, I want to check if I can first categorize the patients who have gait problems from other patients using molecular imaging. To do this, they compared BRGD, meaning postural instability and gait disorder patients with tremor-dominant patients. First, actually, they compared them with the healthy subjects, and then the most important comparison is the second one, which is BRGD against a tremor dominant, and we can see a hypermetabolism in the posterior cingulate gyrus, preconeus, coneus, lingual, and anterior cerebellum. So BRGD patients have a specific pattern that is different from dominant patients. What is important here is that the connectivity between these regions, the functional connectivity, so they took these patients and put them in an fMRI, and during resting state, they tested the connectivity between these nodes, these regions of the brain, and it was actually the less the connectivity, the less the BRGD score, meaning this connectivity is something pathological, and when it is more expressed, the gait is getting worse. Okay, then these patients has a specific pattern that is activated, and this pattern correlates with their gait impairments. Then gait, we said it's not one thing, it's a complex collection of symptoms, including freezing of gait. Are freezing of gait patients special? Is there any metabolic activity that is special to these patients? We can see here that in this study, they saw hypometabolism in the frontal and parietal brain regions. This is important because there is a high correlation between gait impairment and cognitive abilities. And these two regions are responsible somehow for this. Then, freezing of gait is one thing, but there are other things. We said, for example, base variability of gait is affected. In here, they use similar thing to the study of tremor. They took 55 BD patients. They did a resting PET scan. All of the findings that I'm presenting from here onwards are FDG PET, meaning these are metabolic activity, glucose metabolic activity. And they measured the gait. So they studied the kinematics of gait of all these patients. And they took all the different components like pace, rhythm, variability, asymmetry, all these pathological signs. And then they studied the covariance of all these brain regions, meaning they put all the scans and they tried to explain the variability among patients using these scans. And they took the most important components and they checked if these components explain which one of these symptoms. And they found two networks. One network for pace, they call it the pace network. And this is it. It includes several regions of hypo and hypermetabolism, and it is responsible, meaning the higher expression of this network or this metabolic activity pattern, the higher the impairment in pace in the gait of these patients. Another network of mostly hypometabolism was responsible for the temporal variability between steps. And this is important because these two networks are totally separate, meaning these are also two. Now we are getting more into the details. Those two are two different networks that we can target to improve specific components of gait impairments. Then, can we normalize this activity? Meaning we are treating the patient anyhow. We know that this treatment is not super effective for gait, but still many patients get a little bit at least of benefit using deep brain stimulation or levodopa. So can we check if this improvement correlates with, has any metabolic brain activity correlates? Here, they use a gait rehabilitation program. So they took 9 BD patients. They compared them with 5 healthy subjects, pre and post intervention. What we are interested in is specifically the post versus pre. What is different after this rehabilitation? Can we detect with molecular imaging, with this metabolic FDG PET scans, any differences just due to the rehabilitation? And we can see here that they detected increased metabolism in the right cerebellum, as well in the right parietal and temporal lobes. Please keep in mind all these regions. It's not that we will remember them at the end of the presentation, but we should keep in mind that like we are naming so many different regions of the brain that are contributing either to gait impairment or to gait improvement after we are managing the disease in some therapeutic approach. Then, yeah, let's skip this. Deep brain stimulation, effect on freezing of gait. These are patients who improved using deep brain stimulation for freezing of gait. And we see that there is hypermetabolism in the parieto-temporal occipital sensory association areas. So a very large region, they saw that the DBS is inducing more hypermetabolism in these regions. And this hyperactivity is correlated with the clinical improvement. Then there are a group of patients who have gait problems induced by deep brain stimulation. Can we correlate this or specify any region that is responsible for DBS-induced gait problems? And they could also locate this activity, which is a hypermetabolism in the dorsal bonus, the dorsal bones, sorry. Then the effect of our treatment, either improving or deteriorating gait, can be studied by brain metabolic studies. Then, can we predict, can we check the future, what will happen to the patients in case I'm looking at their metabolic imaging? In this study, Professor Isaias took a group of patients who, a group of patients with Parkinson's disease. The first 11 are fallers. What does this term mean? Means that they have their first fall after 6 to 8 months after the scan. This was a retrospective study, meaning they took all the patients who have PET scans in the hospital, and then they collected their clinical information. They checked, they have a group of patients who have their falls, their first fall, 6 to 8 months after the scan, and the other ones who do not have any falls yet. And then we compare them, because we can claim that this scan, which happened 6 to 8 months, half a year before the first fall, is predicting if the patient is falling and if the patient is not. And it is important that they saw hypermetabolism in the left posterior parietal cortex and hypermetabolism in the cerebellum in the patients who are reported here as fallers, meaning these two metabolic activity can predict falls. Then, can we study? So till now, we are studying gait, but during resting, meaning we are studying patients who have gait problems, but when they are doing the scans during resting. And now, why don't we take the patient and let them do the activity and study the gait-induced activity? This is important. In this study, they used fMRI for some, here it was a study on healthy controls, and they used FDG PET for the same group. However, in the FDG PET, they asked the patient to do overground walking, meaning, as I told you before, injection of glucose. The patient is doing some walking for half an hour, then he goes into the scan. Then they studied fMRI. In the fMRI, they did 2 scans. Either the patient is imagining himself doing gait. This is a limitation of MRI that we talked about before. The patient needs to imagine gait. So they either imagined normal gait or they imagined gait with some kind of perturbation, like stopping, then initiation, then stopping, then initiation. And this is some kind of modulation. Modulation is important because Parkinsonian patients do not have problems during continuous walking or steady state velocity walking, but more importantly, when they are initiating gait, stopping gait, modulating deceleration, acceleration, and so on. So it was important to compare these two networks. Sorry, Khadir, 1 second. So what did they find? For the FTG study, meaning the unperturbed gait, primary motor cortex was activated, then the thalamus, but there was a direct connection from the primary motor cortex to the spinal cord which activated gait. But for the fMRI with perturbed gait, there was more things involved. For the perturbed gait, we have more basal ganglia involved, meaning the subthalamic locomotor region, the mesencephalic locomotor region. These are two important regions that incorporate the information that are coming to the cerebellum here, the cerebellum locomotor region, and the information that are coming from the supplementary motor area before passing them to the spinal cord. This is important because this is the region that is impacted in Parkinsonian patients. This is where we implant the electrodes. This is where we see the higher denervation in the DAT scan and so on. So we need to study this. Please, Khadir.
Well, it's just about curiosity, from curiosity actually. So it's you've mentioned that it's a limitation for this technique that patients need to imagine walking, and I don't think that it is much reliable to rely on data that is was taken from imagining walking. So my question is for you or Professor Isaias as well. So would you recommend anyone to start in this field, to start a thesis in this field?
So at the end, fMRI is a legitimate technique that is used. It gives you several additional things. So both of them, they have drawbacks. The FDG PET, its most important drawback is that it gives you one image. There are some techniques that can give you a little bit or more images, but mostly it will give you one image that is reflecting the metabolic activity that happened during the last 30 minutes. Okay, so if the patient has 3 freezing episodes and then he is doing effective walking for 20 minutes, both of them are in the same image. You can't separate them. Okay, then for fMRI, you have the temporal resolution. The patient is in the scan, he is imagining gait. There are some questions about it, but they can even imagine freezing, meaning that the patient is doing imagination of walking, and then they can detect when this imagination is interrupted, and then do the imagination again. So the length of this imagination correlates with their walking outside the scan. Let me say it in one other way. There are ways that you can correlate the imagination activity in the scan with the gait impairment that is happening when the patient is actually walking. If you put the patient in the scan, tell him to imagine gait, they saw that the length of imagination that he reports correlates with the length of gait that he can do outside the scan without freezing. Okay, so this correlation means, okay, that maybe this imagination is equal to the actual gait, but absolutely the patient is imagining at the end. Another thing is that, or let me keep it for the next thing, the next slide, but both of them are important. Each one of them can give you something different. Freezing of gait, something episodic, is more likely to be detected in fMRI because isolate this period. Yeah, you can isolate the modulation, you can isolate the steady state walking. It's not optimal, but It's something that is absolutely impossible in FDG PET. Okay. Okay. So this is the gate modulation pattern. This is the difference between okay, sorry. This is a little bit different. In this study, they asked one group of patients to do PET scans, not patient, healthy subjects, to do PET scans in 2 times. The first time after continuous adjustment of a split belt treadmill. This is an exercise that is testing gait modulation, meaning usually every treadmill has one belt that is rotating. In some laboratories, they have this belt split into 2, and each one of these belts can be rotating in a different speed. So, well, if they want to study gait modulation, what they would do is to do adjustments of one of the belts. Then the patient has to recognize this and modulate his gait based on the speed of the belt so he doesn't fall. So one leg should move faster than the other leg. And this continuous adjustment means for the brain continuous gait modulation. And we can see here that continuous gait modulation has some hyperactivity in the cerebellum, in the paracentral area, also some hypometabolism in the thalamus region. Then let's get back to Parkinsonian patients. This is a recent preprint from our group. In this study, they asked the patients to do 2 scans. The first scan is after resting. The second scan is after continuous walking for half an hour. During the scans, they were also, or not during the scan, because these devices can't enter the scan, they had EEG devices between the injection and the scan. Why is this important? Because I do not have, I told you that we have one scan at the end for the whole brain after doing the task, which is reflecting these 30 minutes. And this is a metabolic activity. Then if I'm having EEG, it reflects the electrophysiological activity exactly in the same period. Then I have 2 modalities working on the same task. And they detected hypermetabolism associated with hypermetabolism, let's say, in the paracentral region and in the cerebellum. And you can see here also some involvement of the visual cortex. This hypermetabolism associated with higher information flow. This information flow is not through the PET scans, but through the EEG. This information flow happens specifically between the precuneus and the supplementary motor area. And this connectivity, this information flow correlates with better gait performance. Meaning in this, we are doing 3 aims. First, we check the metabolic activity. We isolated the regions with different metabolic activity. Then we checked the connectivity between these regions using the EEG. Third, we checked if this connectivity between these electrophysiologically and metabolically meaningful areas mean anything to the kinematic, to the movement and gait impairment of the patient. Okay, then let's check This is one of the last few studies. These are patients with Parkinson's disease. Some of them have freezing of gait, and this is a freezing of gait. If you see the patient is freezing the legs, now is another, yeah. The freezing is triggered by passing through a narrow path, by gait initiation, by turning, by several things. And in this task, they wanted to do a PET scan, but they wanted to make sure that the patient is freezing. So they asked the patient to do gait initiation, passing between two chairs, then doing some turns to the left, then some turns to the right. So if the patient has any sort of freezing, then it will be detected in these 30 minutes happening in this gait task. It is really good that they triggered freezing. However, the freezing itself is also heterogeneous, meaning there are some freezing happening during the turning, some freezing happening during passing through the chairs, some gait initiation, some patients were not able to reach the chairs. So there is some kind of heterogeneity in this, something that is not super preferable because we say it's one image per patient. However, if we compare freezing patients to non-freezing patients, we have more metabolism in the paracentral lobule, and they explain it as increased need to rely on external cues, because in this region we have the spatial imagination in the brain. So higher activity means higher reliance on the input from the outside, from the environment. Another study, they did something, maybe, here, very good. Yeah. Another study did something also similar to trigger freezing of gaits. This is a patient. He was walking between these cones, depending on the colors. The white color, the bright color, he needs to rotate around them, and the dark color, he doesn't rotate around them. So they asked the patient to do 2 scans. The first scan is passing through these cones without doing any turning, and the second task was to go around them and to do this difficult task. It also induced significant freezing, and they were comparing patients with freezing to the patients without freezing, and they saw increased activation in the supplementary motor area and less activation in the parietal cortex. And this is opposite to what was found in the previous study. So this shows us a very important challenge in molecular imaging, or in imaging in general, actually, that there is a lot of heterogeneity, and there are a lot of techniques. At the end, you will have some regions that are popping up showing hypometabolism. However, this is not always consistent. One explanation can be that these 2 tasks were significantly different. Like, there is no significant cognitive load when the patient is walking through a chair and turning to the right, turning to the left. But there is much more cognitive load when the patient is doing this. And this is something important, because cognition and gait impairment are happening in the brain in the same period, in the same region. What should we do? We know the metabolic activity in PD to some extent. We know when the modulation happens, what happens to the metabolic activity. And we know how DBS modulates this metabolic activity. We saw evidence of this, DBS during resting. And we know modulation during, meaning modulation of the neural correlates during gait modulation specifically. Now we need to put all of these together, but still in a standardized manner and during overground walking. Why is it important? Because maybe if we do the freezing in a very standardized manner, happening always in the same way, in the same place, for all the patients, in the same challenging situation, because the patient can find something more challenging than the others. And also overground gait is more important, as we agreed on this. The methods, this is a study we are conducting right now. We actually completed it. The patient comes to the hospital without stimulation or without medications, without breakfast. So the brain is starving for sugar. We start to do the task, either resting or obstacle avoidance. Then FDG injection. This is a glucose, and then the same task for 20 minutes, then the scan. Now, what is the obstacle avoidance? If you look here, the patient is walking and suddenly he breaks for a second and then continues. Why did he break? Because he's putting a virtual reality device, a virtual reality visor, and this virtual reality visor shows him this virtual reality in the lower image. The patient, during these 10 minutes and 20 minutes, is doing always the same task, moving backward and forward, and always seeing this virtual agent crossing his pathway. This triggers freezing of gait, and we showed that in the lab and in the nuclear medicine department. And it is super effective. Why is this virtual reality paradigm special? Because the obstacle avoidance task is happening over ground walking. So the patient is doing the virtual reality, but still is doing over ground walking. The virtual agent, this agent that you see in the lower image, is moving in a very standardized manner based on the movement of the subject, meaning if the patient is faster, this virtual agent is faster. If the patient changes his direction, the virtual agent will also detect the direction and always cross his pathway at 1 meter ahead of him. This means that it is always the same challenging situation, consistent in the patient and among patients. So what did the patient specifically do? 3 scans. The first scan in resting state, the patient was sitting. The second scan, the patient was doing the obstacle avoidance without stimulation. The third task is with stimulation, because we agreed we also want to check the effect of stimulation on this modulation. These are the characteristics of the patients. They all improved from stim off to stim on with a significant difference. They also all improved for the RGD symptoms. We co-register the scan, meaning the scans. This is something that happens for all also the previous studies. They take the scans, the FDG scans, co-register them, meaning to fuse them with the T1 images, normalize them, and this means to wrap the images to the size of a normal brain. It's not a normal brain, it's a template, because we want to overlap all the patients together, right? How can we overlap all the patients together and they have different skull shapes and different skull sizes? We need to do something called normalization, which is we shift the brain to a normal brain, to a template that represent usually 100 of healthy subjects and so on. And then we smooth, so we do not have such an artifact or huge differences between the voxels. A voxel is like a pixel, but in 3D images, it's a voxel. And we are reporting only significant clusters, large clusters that are larger than 50 voxels. What we saw is that during first, we compared the obstacle avoidance without stimulation to resting without stimulation, meaning both scans do not have any stimulation, but one resting, one obstacle avoidance. We see hypermetabolism in the cerebellum and the sensorimotor cortex, hypometabolism in the orbitofrontal cortex. And this happens for all the patients, regardless of their severity, of their gait involvement. The patients who are doing really good, the patients who are doing really bad in the task, they were having this pattern of activity all the same. Then what is important is to compare stimulation on to stimulation off activity during obstacle avoidance. And for this, we see hypermetabolism in the left thalamus, specifically for the patients who do not have significant gait problems, limited gait problems, gait impairment. And we see hypermetabolism in the left superior frontal gyrus and hypometabolism in the right cerebellum for the patients with higher gait impairment. So the patients who are doing worse. Then we have, these 6 regions. 3 regions for the difference between obstacle avoidance and resting, 3 regions between the stimulation on and stimulation off. And we need to quantify this. We say that PET scan, the metabolic imaging of FDG PET, helps us to quantify the metabolic activity. To quantify that, we created spheres of 10 millimeter radius around each voxel, each significantly. So this region, for example, is a cluster of voxels, but there is a voxel usually in the middle that is strongly different, that has the highest deviation between the scans. We centered the sphere around this voxel, and we calculated the standardized uptake ratio in this region, meaning what is the percentage of FDG uptake in this region as a percentage of the whole brain. And we try to visualize them here. We can see for the right cerebellum, the red lines represent the high gait impairment. The blue lines represent the low gait impairment, limited. So the blue lines are for the patients who are doing better. The x-axis represents the 3 scans: resting, stimulation off, stimulation on. Then the y-axis represents the standardized uptake ratio. I'm sorry, I don't know why the images are a little bit shifted here, but this region is the right cerebellum, and we see that all the patients are behaving the same. They have increased activity during gait, and this activity nearly stays the same with stimulation. On the right, we see the induced activity, so meaning the difference between each scan and the other. So the first difference is gait, the dark line, the dark columns, and we see hypermetabolism during gait. The light columns are the stimulation effect, and we see a little bit of hypometabolism in this region during the stimulation. However, it's not significant. Then we want to correlate the activity of these spheres, these regions, to the severity of the symptoms. And when I say the severity of the symptom, I mean most importantly the gait symptoms. The BIGD, meaning the 5 items of the UPDRS that we talked about, and gait is just 2 items. BIGD is a little bit more comprehensive. It includes also the some more axial symptoms like standing from a chair, and something like this postural stability when during the bull test. So what we see here that there is no correlation in the high or low gait impairments groups. The same happens for the right paracentral region. And then let's look together at this right orbitomedial frontal gyrus. This is a region that was also significantly different in a previous study regarding freezing of gait. The frontal regions are really important for gait problems, gait impairment, and cognition together. And this right orbitomedial frontal gyrus, we see hypermetabolism in gait without stimulation. Then this is stable for gait with stimulation. However, if we isolate the blue lines from the red lines, you can see a pattern between stimulation off and stimulation on. You can see it clearer on the right. Let's take the light columns, which represent the stimulation. On the left are the patients with higher gait impairments. On the right are the patients with lower gait impairments. The patients with lower gait impairment have mostly increased activity, induced hypermetabolism in this region, while the patients on the left have more of induced hypometabolism. Let's see the correlation. We can see here a significant correlation. It's 6 points, but still you can see the pattern is very strong. A correlation between the induced, the x-axis represents the induced activity in the right orbitomedial frontal gyrus through the stimulation. Meaning, when I turn on the stimulation, these two patients have a little bit of higher metabolism, and these have a little bit of hypometabolism. And these are the points for the high gait impairment patients. Meaning that if I manage, the y-axis is the percentage of improvement in the BIGD score, meaning the higher the better. If I manage to induce activity in this region, the improvement is higher, and the patients are closer to the low gait impairment group. If I don't manage and I induce hypometabolism, I'm further from the better patients, and I have nearly zero improvement. Let's take the 3 other regions. The left thalamus, we do not see anything super significant. Then the left superior frontal gyrus, another frontal region that is modulated by stimulation. And we can see here also a significant correlation, but in an opposite direction. Meaning, if I manage to induce more metabolism in this region, I have less improvement. When I have less induced metabolism in this region, I have more improvement. Meaning these two regions are acting in an opposite direction. I would like to minimize the stimulation effect or the stimulation-induced hypermetabolism in the left superior frontal gyrus and do the opposite for the right orbitomedial frontal gyrus. The right cerebellum doesn't show any significant correlations. As a conclusion, we can say that there is a lot of heterogeneity and we need much more consistency in studying the brain metabolism. Still, all brain imaging studies have such a large amount of heterogeneity, although they are super important because they give us the metabolic specificity. I can, with the deep brain stimulation, study the effect of the stimulation on the subthalamic nucleus, the electrophysiological effect on the cortex through the EEG, but with this kind of imaging, I am getting to the neurons that are carrying this specific ligand, this specific receptor, and I'm studying them. So it is much more specific. But to use it, we need more consistent pipelines first to analyze the images, because every study is doing it a little bit differently. And there is so much heterogeneity in these methods that can prevent us from taking important conclusions. And this is what we tried to solve with this protocol, doing overground, still standardized gate modulation task, and trying the stimulation effect, the gate obstacle avoidance effect on the same group of patients in a matched analysis technique in the same settings. So we are still working on the other aspects, because in these scans we also study the EEG, the local field potentials, because these patients have deep brain stimulation devices that are able to record the activity in the subthalamic nucleus. And hopefully we update you later on. I hope you enjoyed these 3 hours and a half, and maybe we can do some questions.
Thank you, Ibrahim. That was very, very nice lecture. And most of the studies that were recently at last presented by Ibrahim was really his hard work over the past years. So I hope you really enjoyed that. Any questions? It was pretty much very clear. Ibrahim is very good in presenting scientific data. So if you have any question, well, if you will have in the next days question, just you can also write an email or reach out for us. It has been a lot. There is a lot to digest. I mean, with the information that provided you. If you want, we have regular acquisitions in the lab, and if you want to join and have a look of some of them, just feel free to contact Ibrahim for a lab visit.
Okay, then thank you very much.
Thank you, Ibrahim. Thank you all.
Thank you.
Have a nice evening and enjoy the weekend.
Thank you very much. Goodbye.
Bye.
Thank you. Bye.
Thank you.